Good afternoon, everyone. I'm Melanie Escher with the Arizona Telemedicine Program in the Southwest Telehealth Resource Center, and I have with me Ernestine Nasing Waitua with the AIH AHEC, and we'd like to welcome you today to today's webinar. Get to my screen here. So with the University of Arizona, we respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region, with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. So some webinar tips and notes. When you joined us today, your phone or your computer microphone were muted, and we will be using the Q&A chat function. So if you have any questions, please go ahead and put that in the chat. There's an evaluation that will populate in the background of your web browser. And you can please go ahead and do that evaluation. I will also be sending a link in my thank you email to everybody that has attended today. And there's CME credit available for this, for attending the live presentation. And it is being recorded, and the recording will be posted on our website later on today once it's been processed in a previous webinar. That thank you email will also include this link for future reference for yourself. So this was sent out in the emails, and this was also on the registration information, our outcome objectives, and the accreditation statement and disclosure statement. The university does use a cloud CME system for the CME credits. And if you haven't set up a profile, I'll have that information in my email that goes out as well. We have our standard disclaimer. Opinions expressed in the presentation on the following slides are solely those of the presenter and not necessarily of those of the organization sponsoring the webinar, and the organizations do not guarantee accuracy or reliability of the information provided herein. All right, so again, upcoming webinars will be coming up, and we have actually a couple more that we're working with Ernestine on. One's coming up in August 13th and another one in September, on September 3rd. So please be sure to double check our website for those when those registrations are open. And again, your opinion is valuable to us. Here's the link again, but it will be populated in a browser behind your window when this is done, but I will put that link in the chat towards the end of the webinar. So first of all, I'm going to introduce Ernestine Nasing Waitua. She's the educational coordinator with the AIH AHEC, and she'll talk a little bit about the AHEC, and it's one of the newest ones in our system. Ernestine?
Yeah, thank you, Melanie. Also, big thank you, Anna, for presenting today. Just wanted to say hi to everyone who's joining us today. The American Indian Health AHEC we're so grateful to the Arizona Telemedicine Program and the Southwest Telehealth Resource Center. The American Indian Health AHEC is in its first operational year, so we are so appreciative of this partnership as we grow our programming. I was just gonna share a quick abbreviated summary about the American Indian Health AHEC. AHEC is acronym for Area Health Education Center. The American Indian Health AHEC is one of 6 area health education centers in Arizona. The American Indian Health AHEC works towards enhancing the tribal healthcare systems and works to strengthen current workforce strategies and solutions. We are involved in a variety of activities, including youth healthcare, career exploration programs, community-based experiential training, the AHEC Scholars Community Immersions, and also events like this event today. We have activities for continuing education for healthcare professionals. Our team is made up of Jeff Axtell, who is our director, Tashina Machine, who is our youth program coordinator, and myself. And yeah, just thank you to everyone who's joining us today. We hope you find this webinar informative and engaging, and we hope to see you next month as we partner again with the Arizona Telemedicine Program for a webinar on advanced directives, which will be presented by Carla Sutter. That webinar is scheduled for Tuesday, August 13th from noon to 1 p.m. with registration opening soon. Thank
Great,
you.
thank you, Ernestine. And yes, once that registration is open, all of you that are attending today, I'll send you an email with a heads up that the registration is open as well. All right, so without any further ado, we're going to come to our presenter today on forensic healthcare in tribal communities. Today we have Anna Lennox. She is the sexual assault nurse examiner coordinator for the White River Service Unit in the IHS Phoenix area. Ms. Lennox is a highly motivated and energetic nurse who has worked tirelessly, that's a tongue twisting word, to pull together the nursing staff, law enforcement, and the tribal community to provide comprehensive care and promote justice for victims of violence. She's received a 2023 IHS Division of Nursing Services Nurse of the Month in February 2023 and the 2023 Victim Service Award from the Department of Justice. So without any further ado, I'm going to go ahead and stop sharing here and let Anna pull up her slides. And then I will pass the mic on over to her and we will get started. And they're coming up. Okay, great. We can see those. Just
all right. Perfect. I'm going to try to get the chat on my screen too, so I can see that as well. Okay. All right. My name is Anna Lennox. I am the sexual assault nurse coordinator for the White River Service Unit. I'm very excited to be here today. I'm excited to share this topic. This is something I'm very passionate about, and I still actively work in this, this area of nursing. So I'm really happy to be able to talk to you guys today because it's an area of nursing that we don't really talk about very often, and it's emerging and we're seeing it in more and more places, and it's really growing. And so I'm excited to be able to communicate what forensic nursing is to you today. Just a little bit about myself. So I have been a nurse for 10 years, and 9 years of that has been here serving the White Mountain Apache in White River Service Unit. Majority of that time was spent in the emergency department, which I do have to give a little bit of a warning. My office is located in the ER, so hopefully there's not a whole lot of noise. I did put a sign on my door saying that we're in a webinar, but just a heads up, if you hear some weird things, I am located inside the emergency room. So just letting you know that. So as far as what I've been doing forensic nursing for 7 of the 9 years I've been here. And I got to be the coordinator for this program 3 years ago. And I'll talk a little bit about what my program does and the services that we offer as I go through my slides. But when I started working with victims of violence, there was only one examiner at the time here in White River. And now our program is really thriving, and we have 8 examiners and another 8 in training. So within the next 3 months, I'm going to have 16 examiners, which is really pretty incredible for such a small location. As White River, we see a lot. So I do have to, before I get too much into it, I do need to just let you know that this material is the result of work supported with resources and the use of facilities at White River Service Unit located in the Phoenix area of IHS. The contents do not represent the views of the Indian Health Service or the United States government. And I have no further disclosures to make. I do also want to be aware that some of the topic matter might be triggering to some who have experienced violence. So I do just want to give a trigger warning that we will briefly discuss intimate partner violence, sexual assault, and child abuse, among some other kinds of violence. I'm not going to be going into explicit details here, but I did want to give that warning ahead of time to just be aware that people that are on this call may have experienced violence or know somebody who has. So if at any time you need to step away, we understand. So after today's webinar, I hope that you will be able to define forensic healthcare and forensic nursing, that you will be able to identify some of the challenges that these forensic teams face in tribal communities. And then that also you will have a basic knowledge of what every provider, what every clinician, what everybody in every area of medicine needs to know in order to provide really quality and holistic and trauma-informed care for victims of violence. So actually, before I even hit on what a forensic nurse is, what is forensic healthcare? So the way I describe it to people who ask me is forensic healthcare is the intersection of medicine and law. So when law enforcement gets involved with something that's also medical, that's where the forensic nurse can come in. So forensic nurses then are specific or specially trained nurses that help to serve victims of violence and abuse, such as human trafficking, intimate partner violence, which we used to know as domestic violence. Now we use the term intimate partner violence. You'll hear me use that term. Child abuse cases, elder abuse cases, homicides. If their law is involved with some of these cases, mostly that's where the forensic nurse will also be involved. The forensic nurse can collect evidence, they can photograph injuries, and they also work with victims of violence to help get them plugged into services like mental health services, if they need testing for STDs or STIs. If they really have any needs socially as well, the forensic nurse can assist with that. So one question that I get from different clinicians is why nursing? Why has forensics really been picked up by the nursing department? And there's a couple reasons, and most of these are my opinion. However, there is also some really great articles that you can read to about forensic nursing and why it's under the scope of nursing. But kind of in summary, the reason why it's under nursing and not under like MD, DO, PA, and P is because nurses are really trained in that holistic care, and not to say that other clinicians aren't, but nurses often have the time to sit down with these kind of patients that require a lot of time. We'll talk about the exams and how much time they take. It falls within the scope of the nurse, so the nurse is able to complete all of the areas that forensics require. We are more readily available than some other clinicians. The exams, especially sexual assault exams, generally take between 4 to 6 hours to complete. And because of chaperoning and making sure that people are feeling comfortable, there's usually 2 nurses in a room. That's a lot to ask from 2 clinicians. For instance, in our ER, we have generally, especially overnight, we just have 2 clinicians in our emergency department. So there are more nurses available in hospitals and clinics to perform these tasks. And because it does fall within the nursing scope, it is more cost effective to have nurses trained. The nurses are present in almost every department in the hospital. So PHN, public health nursing, I have some public health nurses that are trained as forensic nurses, whereas there is very few clinicians in the public health department. And then there are many departments that don't have 24/7 coverage of clinicians, where they do have 24/7 coverage for nurses. So that's some of the reasons why this is falling under nursing. We also have some really cool associations and people who are working on getting accredited to be able to provide education for nursing in this growing field. So one of them is the International Association of Forensic Nursing. So if you're not familiar with that, it's a great resource if you are an RN on this call. They have so many different training opportunities for forensic nurses. For training wise, the forensic nurse, it's going to differ depending on what location you go to, but my nurses here, they all have a 40-hour training that is for adolescent and adult sexual assault. They have a 40-hour training for pediatric sexual assaults. They take an 8-hour course for child abuse recognition, and they do a 12-hour intimate partner violence examination course as well that helps to teach the examiner about doing strangulation exams. And we'll talk a little bit about that too. And then they do countless hours of clinical time shadowing myself or any other forensic nurse. Most of these cases come in through the emergency department. So the majority of my nurses are within the emergency department. We're also one of the only 24/7 departments in the hospital, so it makes sense to have majority of our trainer or our nurses here in the ER. But we do also have forensic nurses trained in OB department, in our family care unit, which is like our med surg floor. The public health department has 2 nurses there trained as well. So we're trying to get different nurses from different departments trained, because we all know that victims of violence present themselves in every department of the hospital, in the community. So the more people we have trained, the more resources we can offer to the victim. So, why is this important? And I think all of us on here know a lot of the statistics and understand that violence is an issue in our entire country, in every region. However, Native Americans and Alaska Natives are disproportionately affected by violence. And that's statistically proven. So one of the more recent studies, so I think it was finally published in 2016, but the research went from 2013, that 4 in 5 American Indian and Alaska Native women and men have experienced violence in their lifetime. And of that study, 56% of women and 27% of men experience sexual violence. 55% of women and 43% of men experience intimate partner violence. And the American Indian and Alaska Native children are 7 times more likely to be victims of child abuse than the national average. So violence is something that is encountered daily in tribal communities, and it is not just a community issue. It's not just a police issue. It's a healthcare issue. Violence is a healthcare issue. We know that violence leads to many healthcare issues. We know that PTSD comes from victims of violence often experience PTSD. They have an increased rate in psychiatric disorders, substance abuse. For the pregnant victim, miscarriages are higher in victims of violence, have higher rates of STIs in groups of people who have been victims of sexual violence. And we know that repeat victimization, so whether that's another sexual assault or an intimate partner violent relationship, we know that violence can often compound on itself. And we see people who've experienced all kinds of violence. We are now talking more about trafficking, especially in the form of sex trafficking. We know that a lot of our youth are being exploited for sex. There's just so many different elements to violence. And it's finally being acknowledged that violence is a public health issue. The CDC is now saying, yes, in the World Health Organization, yes, violence is a healthcare issue. It is affecting people's lives and their physical lives, especially now that we're talking more about ACEs and childhood trauma, and understanding how trauma affects our physical health. And that goes into adulthood as well. So what kinds of violence does the forensic nurse help to participate in? So what kind of violence are we helping those kind of victims? So intimate partner violence, formerly known as domestic violence. We see many child abuse and neglect cases here. Child neglect is one of the hardest cases to tackle as a healthcare worker. So we have a team that really dives into neglect cases and determines plans moving forward. In the past, we've only thought of forensic nurses as the SANE nurse, so the sexual assault nurse examiner. That was kind of the coverall. We thought that that's the only thing that a forensic nurse could do is the sexual assault exams. But now we're seeing that all of these really intertwine, and you might have a child abuse case that's also a sexual assault, that's also a human trafficking, that also dealt with IPV. And so you're seeing that all these things are weaving together. So forensics is kind of beefing up its training to meet those needs. I've been involved with several patients that have come through our ER that ended up being homicides, any assault with deadly weapons, elder abuse. there's so many different elements that we see, especially in the emergency department, that the forensic nurse can help with. Again, it's growing. There are areas in Alaska that are using forensic nurses in death investigation. It's been a big conversation the last few years because nurses do have expertise, especially in sexual assault cases, that have been proving really beneficial in death investigations as well. Part of my job as the coordinator here is to implement screening to catch all of these kinds of victims of violence in our emergency department especially, but also in the clinic and in any kind of outpatient setting as well. Because we don't know what we don't know. If we're not screening appropriately, we might not know that people are experiencing this kind of abuse and how we can help. So we're always working to update our screening processes and how we're able to intervene with those patients. So one of the big takeaways is forensic nursing is more than the sexual assault nurse, can do more than the sexual assault exam. But I will talk about that exam because that really was the cornerstone of the starting of this department and of forensic healthcare, was the sexual assault exam or the SANE exam. So any patient who is a victim of violence can have a really thorough exam performed by a forensic nurse. All of the forensic nurses are trained on forensic photography. So that's the use of scales, which are, if you think to the, CSI, it's the measurement tool that we use to see, how big a wound is or something like that. We're trained to use different measurement tools, how to photograph injuries, that they could be admissible in court, because with photography, you have to be careful, especially in this day and age where you can augment photos pretty easily, or just change your, the angle that you're at can augment something like an injury. So they're trained on how to do photography that's admissible in court. We're also trained on documentation, really thorough documentation. I'm talking about documentation that takes sometimes hours to do, where we meticulously go through every injury, categorizing it, giving it, diameter. We go through everything. It's very, very, like I said, meticulous, and it can take a really long time. And in that documentation, we also try to, give the patient that opportunity to talk to us, to tell us what happened, give those details. And oftentimes our report with the victim is more thorough and more, they give more details than even with law enforcement, because there's a little bit more ease when you're talking to a nurse versus somebody in law enforcement. So I always tell my law enforcement partners, don't be offended if I get more in their report than you do, because I'm the nice nurse and you're the big scary officer. And so they might be giving me more information that can be put into their report. And then we do a really thorough physical assessment, so a head to toe assessment. There's times that, especially in the emergency department, where the provider is not able to really do that detailed head to toe. And so we come in as that secondary resource. And there's been times where I've gone back to the provider and said, hey, I found this on my exam. I'm really concerned, especially in strangulation cases where they don't reveal that right away. In my report, they say, yes, I was strangled. And then I noticed some of the telltale signs of strangulation, maybe some petechiae, something like that, because I'm really going through really thoroughly head to toe. I can spend more time with this patient, and I'll go back to the provider and say, hey, just per what I saw, my recommendation is that they get a CTA or an MRI or something like that, so we can work in conjunction with other clinicians to say, hey, this is what I saw on my exam, or what did you see on your exam? So that can be really helpful for providing really good medical care, because ultimately that's why they're here, to get really good medical care. We also do mental health screenings and interventions. We know that violence is a pandemic. We also know that in tribal communities, suicidality and completed suicides are a huge issue that most of the tribal communities are always battling. We know that trauma, we know that violence, that substance abuse, these all go hand in hand with the increased rates of suicide. So we want to make sure that we're paying attention to mental health screenings. We use the ask questions. So it's the 4 questions that ask about recent thoughts of suicide or any attempts in the past. Make sure that we're doing screenings on intimate partner violence as well. And we start that at age 12, although we see much younger experiencing IPV now. We do start those screenings at age 12. Because again, we know violence does not happen in a vacuum. All of these things go together. We also do a lot of interventions when it comes to substance abuse. We want to make sure that we're addressing those needs too, because unfortunately, substance abuse does increase the risk of polyvictimization. So we do want to pay attention to that. We can also offer STI prevention and pregnancy prevention, as well as testing. And as part of our follow-up, we do follow the CDC guidelines for STI prevention. So we try to see them within 2 weeks, 4 weeks, 3 months, to just make sure that they haven't contracted something from the assault. The day they come in for their exam, unless they're coming in late, generally, if they are testing positive for something, it's not from that assault, it's from previous to the assault. So we want to make sure that we are doing follow-up care with them. We also treat them prophylactically. We do an azithromycin, we do ceftriaxone, doxy if indicated. We're seeing a lot more literature about doxy. We have, incredibly high rates now in the country of syphilis. So we test for syphilis, we test for HIV. We do all of the basic STI prevention screening that I'm sure everyone does. And the pregnancy prevention, we offer the Plan B and Ella. I prefer Ella because it is more, it can be used in a larger population. It can be effective at pregnancy prevention for up to 5 days. So for your late disclosures, that's a good option. It also works better with higher BMI. So I tend to go more toward Ella with majority of patients looking for pregnancy prevention within that window. And then another thing that the forensic nurse can do is legal testimony and consultation. So I've been called to court, both in the tribal courts and the federal courts as well. I'll talk a little bit about that here coming up, about jurisdictions and why that happens. But I've been to several different courts and was able to give testimony as a professional forensic nurse as to what my findings were. And only a few of them were sexual assaults, but more often it's an intimate partner violence relationship that ends up going to court, because there's usually more physical findings that can be documented and taken through to prosecution. So we can offer that testimony and we can consult with legal teams to say, this is what this means. In child abuse cases, we can help work with our local police department to say, when they mean retinal hemorrhaging and a subdural head bleed, they're saying that this is incredibly suspicious, if not definitive, for non-accidental trauma or child abuse. So being able to interpret medical jargon for legal can be incredibly helpful, and nurses and doctors and everybody can be really, really helpful in that realm. So the medical forensic exam also involves DNA collection. And this is what people think of a lot of the swabs and the DNA collection because of movies and Hollywood and the term the rape kit, which is really sounds a lot scarier than it is. It's just a box. I have a bunch behind me. It's looks very unassuming. Excuse me. But the forensic exam really is comprised of what I already talked about. So photography, documentation, the physical assessment head to toe, the screening for mental health and other interventions, STI prevention and pregnancy prevention. But it also, and this is mostly specific to sexual assaults now, we are adding DNA to other kinds of violent crimes as well. But for now, mainly DNA collection is for sexual assault kits that are being done. We can collect all types of DNA. And we use what you'll see in the second picture here is a cotton tipped applicator. It is a Q-tip, nothing super fancy. It is in a sterile packaging. We do wet them sometimes we leave them dry. If you do the training, we'll go all into all of that. But in essence, we're just using a cotton tipped applicator to try to very lightly, touch those areas that we think a perpetrator might have left some of their DNA. So there's all different kinds of DNA that can be taken off of a victim's body, because in cases, especially of sexual assault, the patient's body is the crime scene. So what's left behind of the perpetrator can be what we collect. The first picture is the, I've heard it pronounced so many different ways, a buccal swab, buccal swab. I lean on the buccal side. You can fight on it, whatever you choose to call it, but it is the swab for the DNA of the cheek cells. So like what would be done in like a paternity test. Okay, so you're getting the patient's cheek cell, and that is your control. Because when you're analyzing all this DNA, we want to know what's the patient's DNA and what's somebody else's DNA, or what we would call a contributor DNA. So we need to get that control sample. So in every case, everybody gets a control sample. Some other DNA that we can collect is touch DNA. That is coming a long way. That used to be almost non-existent when DNA came out. And please keep in mind, DNA has only really been something viable since the 90s. So again, forensics is still very much in its infancy as far as every area of forensics goes. But touch DNA, even within the last 5 years, has come a lot further than we thought was possible. So touch DNA is still the hardest to get, and it does depend on the perpetrator. So if a perpetrator is like, say you're like me, so I get kind of sweaty palms sometimes when I'm nervous, like right now, right? I got sweaty palms. Okay, so if I was to touch something, most likely I would leave more skin cells behind, which contains the DNA, than somebody who maybe isn't feeling nervous, doesn't have sweaty palms. They might not leave a whole lot of DNA behind. So in those cases, it really depends on the perpetrator. And this is a really gross word, but how much they slough off skin cells. It's like one of my least favorite words, but alas, nothing else to use instead of it. But so that kind of contributes to whether or not we can get touch DNA. The sneezing, spitting, all of that, we look at those, especially in cases where the patient was bitten by the assailant, or they were kissed, or they have hickeys on their neck or anywhere else on their body. We're going to swab those areas for saliva. And then blood, of course, that's the gimme, right? So if you see blood and it's not the patient's, of course, we're going to collect that. And then what everybody thinks of, right, is the semen, the DNA of, secretions. You can also identify female secretions as well. And a secretion is also not a word I love to use, so sorry. But cases that involve semen or seminal fluid, very rare. It, again, not like the movies. It's not everywhere. It's actually very hard to find and even identify. So those are the different kinds of DNA. Once they're collected, we put them in a kit. We send them to the crime lab. So whether that's federal crime lab or state crime lab, and then they get the cotton swabs get cut up, and the scientists run it through testing and try to extract DNA and try to identify what's the patient's and what is not the patient's. And then it goes into the combined DNA index system, or CODIS, to see if there are any hits. Not like the movies. It's not like, doesn't pop up a face of a guy and it's like, we got our man. DNA is very complex, and that could be its own discussion as well. And with probably people who are a lot smarter than me, I have met with the crime lab, and they have kind of talked about their processes and what they do and how they work. And it is very in-depth and not at all as easy as I'm kind of glossing over here. It's a very stringent process. When it comes to DNA collection or performing the rape kit with DNA in it, you have 120 hours to get that collected after an assault. So adults and teenagers, so adults and adolescents, they have 120 hours to get the full kit with DNA. Children have 72 hours. That's per the DOJ's national protocol. There are many pediatric hospitals, especially I've seen cut off at 24 hours. I've seen some cut off at 48 hours. But for majority of protocols for children, it's 72 hours. One of the first questions people ask is why, sorry, just looking at the chat. Why 120 hours for adults and 72 for children? What's different? One of the biggest differences is that 72 hours is actually the golden period of DNA collection for anyone. However, medical forensic exams can be actually therapeutic for adults and adolescents because it's an opportunity for us to look over their bodies and tell them what we see. And especially with adolescents, we're also affirming if things look normal, which is what like every middle school, especially girl, wants to hear, right? Everything looks okay. I can still have children. I look okay down there. So we extend that period to up to 5 days for the adult and adolescent because we can actually give them some clarity about what's going on with their body. With a child, you can't explain what's going on. It is very hard not to have some trauma from that exam, especially if a sexual assault did occur and now we can re-traumatize. So that's why we do the cutoff at 72, because if we're going to collect DNA, we want to make sure from a child that it's within the best window of opportunity for us to actually obtain it if we're going to put them through that. If you are doing an assault kit on a child and it's a prepubescent female, just FYI, you do not use a speculum. You do not use any internal anything. If you haven't had your period, you don't get a speculum. In females, just again, if you do the training, you'll go all into a lot of these details. So the forensic nurse can exist in all kinds of capacities. You'll see them at freestanding clinics that offer sexual assault support. Many big cities don't have a forensic program within their hospital. They rely on freestanding clinics. So in the hospital or in the clinic, you meet with the patients and give them their options, let them know what they can do, that they can speak to law enforcement, that they don't have to, letting them know what their victims' rights are. You can meet them in any department. I work out of the emergency department, but I have seen many patients in clinic with their PCPs. I've met with them in the OB department. I've met with them in the inpatient department. I've met with them out in the community. Ultimately, it's, again, victims come to every healthcare setting. We see these victims of violence. One of my favorite parts about my job is doing a lot of coordination with community outreach, because we have to be cognizant of our partners. We have to be cognizant of our tribal communities, of our partners that are already working with violent crime victims, of how we can be educators to the community. Again, a lot of times my role is just to explain what a medical finding is to a patrol officer. They did not go to nursing school or med school. They don't know what petechiae means. They're not sure what the meaning behind a subdural hemorrhage is or something like that. So a lot of it is just being able to coordinate with your community partners. You have to. So that kind of leads me though also into the challenges that we face in tribal communities when it comes to delivering really excellent care to victims of violence. If you have worked in tribal communities, then you understand or have seen, the way I describe it is there are a lot of hands in the pot when it comes to prosecuting and investigating violent crimes in Native country. It just so many people are involved, which can lead to a lot of the issues that we know exist when it comes to prosecution and seeing, the justice for victims. So in majority, not all, but majority of tribal communities, you will have a local tribal law enforcement that will be the first to investigate a crime. And it'll be only crimes that occur within the reservation that they serve. If a tribal member commits a crime outside of the reservation, then it does not get handled by tribal law enforcement. It would get handled by whoever that jurisdiction is. You also have the Bureau of Indian Affairs. So that's the Department of the Interior. They have the BIA. They do lots of things within the BIA, but one of them is investigate crimes. They have special agents that are assigned to investigate crimes, major crimes on tribal lands. Then you have your other federal partner, the Federal Bureau of Investigations, and they come in and they also help to investigate crimes and prosecute major crimes on tribal lands. So you have local, you have two federal agencies that, at least in our area, they do 1 week BIA's on call, 1 week FBI's on call, and it varies. So you might not know who you're going to be talking with, and they will be the ones investigating these crimes. In our area, we don't have designated detectives that investigate sexual assaults or major crimes. Some reservations or some tribal communities do have detectives that they employ through their tribe. Another thing is that depending on the circumstances, depending on who the assailant is, it could be state jurisdiction too. Follow me here, okay? This is a complicated, this could be its own lecture as well, is just jurisdictions and when it comes to tribal communities. So it depends, who prosecutes depends on the identification of the offender, the identification of the victim, the type of offense, and where the crime was committed. And when they say identification of the offender, they mean the nationality or the race of the offender. So if the offender is a non-native, then federal agents would have to prosecute, or state. If it's a native, then it could be tribal, federal, or state. Everybody could have their hand in the pot depending on what the case is. There is something called concurrent jurisdictions. So that pretty much means that where we know that we are not able to be prosecuted for the same crime twice, right? That's the premise of double jeopardy. In the United States, we are protected from being tried for the same crime twice. I kill my husband, I can only go to trial for it once. If it gets acquitted, it gets, if they're not guilty, they can't take me back unless there's some kind of things they can possibly do, but it's really, really hard. That's double jeopardy. Can't be tried for the same crime twice. In tribal law, you can. So we have many cases that are tried tribally in tribal court, and then also they can be found guilty in tribal court. Then they'll also go to a federal court and also be found guilty. So that's called concurrent jurisdictions. There's no double jeopardy law that applies to these kind of cases. So that's something interesting. A lot of people don't know that. You could also, I've had this happen. I've had two non-natives in a domestic violence dispute on the reservation in a different county. And because this reservation is the size of Delaware, it was in the county that's very far away, Gila. And so I had to call that department for that incident. So it can get really complicated as to who's taking what case, depending on whether the assailant and the victim are native and where things occurred. There's a few, if you're interested, I try not to bore you too much. There's a lot of attorneys in my family. I probably should have gone to law school, but I do love nursing. So don't get me wrong, but there are a lot of laws that really dictate, all of these jurisdictional things. So let me see, I saw a question just popped in. So does the jurisdiction depend on where the assault occurs or whether medical care was given? Yeah, excellent question. So it actually will depend on where the assault occurred. So I could see patients here that were assaulted in Phoenix, that were assaulted on the San Carlos reservation, that were assaulted in a different state. I've had that happen as well. I would then have to call the jurisdiction of where that assault occurred. It's a great question. Yeah, not necessarily where the medical care is given. Because I'm in a government facility, I can see any person who is registered tribal member or veteran. Here at IHS, I can do their kit, regardless of where an assault occurred. We can still do it. Just need to make sure that that jurisdiction allows for, you know, certain timeframes, or I just have to check with the jurisdiction, make sure that they are going to be taking this case. But some laws that might help to kind of shed some light as to why the laws are this way, why the jurisdiction applies. So just a few, there's a lot more, but just a few. The Major Crimes Act of 1885 was kind of the start of the federal government coming in and prosecuting crimes between Native Americans on the reservation. So it's only the major crimes, so they're not picking up misdemeanors, but kind of the big crimes, right? So murder, manslaughter, rape, assault with intent to kill, arson, incest, burglary. I think they're up to 16 different crimes now that federal agents can prosecute, and they come in and investigate and prosecute. And that's what started the concurrent jurisdiction with no double jeopardy laws. Started back in 1885. Then since then, you've had, I'm going to skip the tribal law and order, the Indian Civil Rights Act of 1968. It was part of the Civil Rights Act, but they added a kind of a portion on just dealt with Native Americans. And it says that the tribal governments do have to extend some of the civil rights that United States citizens have to tribal members as well. That actually needs some clarification on too. So I'm kind of waiting to hear back on that as to if all tribes have to adapt that. Because the Tribal Law and Order Act and the Violence Against Women's Act that were both passed through the House, through Senate and Congress and everything, they are actually optional for tribes. So I'm waiting to hear if the Civil Rights Act is also optional for tribes. The Tribal Law and Order Act is if the tribe meets certain qualifications, they are able to prosecute defendants for up to 3-year sentences. Right now, the majority of sentences in tribal code is only about a year. So, and many tribes don't have a code for murder or some of these other violent crimes because the federal government has investigated and prosecuted them for a really long time. So, majority of tribal codes will only give a year of being incarcerated. If the tribe, so this is VAWA and Tribal Law and Order Act are pretty, they have a lot of similarities. So we hear a lot about VAWA, the Violence Against Women's Act. And what it says is that a tribe can prosecute non-native offenders. So if a non-native offender comes onto a reservation and assaults his girlfriend, who's a Native American living on the reservation, right now, most tribes cannot prosecute that non-native offender. So the Violence Against Women and Tribal Law and Order Act said that if the tribe is able to have bar-appointed judges, so they went through law school, and they have attorneys, and they have attorneys available to the defendant, then they can prosecute. But that is only, of the 574 federally recognized tribes, only 28 of them fall under VAWA. So that's about 5% of tribes are actually able to meet those standards of having bar certified judges, of being able to offer defendant an attorney, because under the US Constitution, you have the right to defense, you have a right to representation, where under a lot of tribal codes, you don't. So that's why they can't prosecute non-natives unless they fall under the VAWA and Tribal Law and Order Act. Again, this is a lot. This could be its own thing. I'm going to move on because I want to get to this, which is what can all healthcare providers do for victims of violence. So number one, this is the first thing I do to educate my clinicians in the emergency department here. You deliver quality care to a healthcare patient, because ultimately they came to your emergency department, your clinic, they came to a healthcare setting most of the time. Like, there are standalone clinics that's all they do. But if they're coming in through your ER or your, inpatient setting, they're coming there to seek healthcare, and you need to treat them like a patient. And remember, especially if they come into the emergency room, that they're an emergency patient first. One of the first cases I ever worked, it was I'm not going to go into details about it, but it ended up being a trauma. And initially it was a sexual assault, and then it quickly deteriorated into a substantial trauma. So making sure that you see the patient for an ER patient first. Don't be afraid to go in the room. Don't be afraid to look at your patient, to even touch your patient, wear gloves, but interact with your patient. Because I often see that when people see that somebody's there for a sexual assault, for domestic violence, IPV, child abuse, the clinicians get really scared and they don't want to go in the room because they don't want to impact the case, right? They don't want to hurt the DNA. Okay, the medical forensic exam can be very important for prosecution and all of that, and even for administration of good medical care. However, the most important thing is that they are cared for medically by their clinician, and we don't want to take away from that. We can still do an exam, even if they change their clothes, even if they ate something. We want to make sure that it's trauma informed. Are we treating them like they're lepers and you don't want to go in the room? Don't go in the room and talk to your patient. Now they're already feeling alienated in a really, really trying time. So don't be afraid to talk to your patient like a human being. Make sure that no matter what jurisdiction you're in, know your mandated reporting laws. In some locations, you might be mandated to report intimate partner violence. Some locations, you may have to report sexual assaults. You need to know what your local laws are. And that means reading your tribal code if you're working in tribal communities. I have mine saved to my desktop. I refer to it every day almost because it's different than the Arizona state code. So know your mandated reporting laws. What do you have to legally tell law enforcement or social services about? And then work with your facilities to ensure that you have the resources available to respond to victims of violence. What are your local resources? Where are your safe houses? Make sure you identify champions in your department or your hospital that are people who work with victims of violence. Is there a family advocacy center? What do your policies look like? How do your policies show how you're supposed to treat victims of violence? And then one especially huge area for my medical people here who are documenting an electronic health record, our documentation language matters. How we talk about a victim of violence is incredibly important. Number one, all of your documentation should not be subjective. You should not be putting your feelings into any kind of medical documentation. But there are some things that we do non-intentionally that kind of do put our feelings into our documentation. And I don't think if clinicians knew it, they wouldn't want that to be presented that way. So one of the things that I am like, man, it gets me riled up is when I see medical people putting that that somebody was choked by another person. If you're in medical, you know choking is the internal blockage of the trachea, right? So it's the internal or esophagus. It's not, it's your kid swallows a quarter and they're choking, okay? Strangulation is external pressure, okay, put on the neck. And it's a really big distinction. One is inside, one is outside. So we're medical people, we need to use the term strangulation. It's a really big one. If you look up anything about documentation, strangulation, don't put choking. Unless the patient states, he choked me, put it in quotation marks, patient states, he choked me. We know our patients still use the term choking quite often. One thing that I get a lot of pushback from providers, still using the words alleged sexual assault. We don't use, especially in the ER, you know, somebody comes in with stomach pain. I don't put alleged stomach pain. I put stomach pain. I put pain, right? It's subjective to that patient, but I don't put alleged. It's the only thing that we use alleged for is sexual assault. You're adding that word and it's giving a connotation of disbelief and legal jargon, which we don't need in our documentation. So that's one, and it's hard because for my clinicians on here, you know that the ICD-10 codes or whatever ICD we're at now do have alleged sexual assault. So that's a lot to do with the whole process of we need to change that language from the ICD codes as well. Because there's also a sexual assault by history is fine. That's a totally fine one, or there's just usually an ICD code for sexual assault. So those are some things to keep in mind as well, as even your codes that you're using for billing or reimbursement. And avoid using words that imply consent. So patient had sexual intercourse with so-and-so, or patient had sex with so-and-so. That implies there was consent involved. And if it's a sexual assault, there wasn't consent involved. So, describe what happened, but careful with some of the words that we're using. And again, chart what you see, not what you think happened. Okay, I've seen it in charts. It makes me cringe. Like, well, I don't think that happened, or something they'll chart and they're like, oh my gosh. Okay, so leave your own feelings out. You can use patient quotes. They're actually really helpful, especially when cases do go to court. Only when appropriate. You don't want to, maybe especially if somebody's using some colorful language, or maybe there's some alcohol involved, maybe you don't want to put all the quotes in. But if somebody says so-and-so, put their hands around my neck and squeezed, quote unquote. That's a really powerful quote. Or one that's really powerful is when a victim says, I thought I was going to die. That really tells you how severe an assault was and how scared they were. That's a really powerful quote to use. The other thing, when you're talking with the victim, I'm careful with victim shaming, and we don't do it intentionally. And I have been guilty of this as well until I really changed the way I'm talking to victims. When I say, I used to say, you don't want this to happen to somebody else, do you? And that's putting what that person did on the victim. So it's their fault if that perpetrator goes out and rapes somebody else. Now you're putting that on the victim, and that's not fair. And I was guilty of that as well. And I still hear it a lot. Like, well, you don't want that to happen to somebody else now, do you? And so we need to change the way we're talking to victims like that too. We don't mean to. We have good intentions. We want justice, man. We want those bad guys put away. But we also don't want to coerce or guilt a patient into making decisions that maybe they didn't want to make, or maybe not doing an exam or not talking to law enforcement. And then talking negatively about the offender in IPV cases, be careful. That victim might go back to the offender, and you want to leave that relationship open-ended between you and the victim, because if they think that you are going to be disappointed that they went back, they might not come to you for services. They might not come back to you for help. So try not to talk negatively about an offender, especially in an IPV situation. You can just say, I'm really sorry that happened to you, without being like, that guy's a scumbag, or how could you ever go back to him? So careful with negative talk about offenders. When it comes to children, try to avoid talking to kids. They're going to get interviewed. But if they say something without any provocation, then that would be kind of going back to the quotes. You can put that in quotes, but try not to ask too many questions, because you don't want to lead that child to saying something, that could be used against the entire case. But again, they're still patients. We want to make sure that they're safe. And so just making sure that you're listening to the victims too, and really just painting the picture of what happened, because we might look at these charting later on down the road. And I want to remember what happened and be able to recount that, because we know that most cases take years to go to trial. So it's really good documentation is really helpful. So I have my sources. I can send more of them out, because I actually added a few yesterday. So my sources, and I know I'm cutting it really, really close for questions. Sorry.
No, that's quite all right. Anna, thank you very much. So yes, anybody, if you've got any questions, please go ahead and put it in the chat. We'll just take a couple of minutes. I've got a question. What's the difference between the IPV, which would be
Intimate partner violence.
Intimate partner violence, compared with DV, which is just domestic violence?
Mm-hmm. Yeah, so they're starting to change that verbiage. You'll see it a lot in medical documentation. Domestic violence involves all violence that occurs within the home, and intimate partner violence is really specific to that relationship. So ex-husband, current husband, ex-boyfriend, current boyfriend, sexual partner, all of that. And we also know that not all people who are in relationships are living in the same home. So it is
Gotcha.
kind of it's a very broad, domestic violence is a very broad term, and it's also a little outdated.
Gotcha. We have a question in the chat. In
Yeah.
Arizona, does SANE need to get extra training to do forensic work for non-sexual assault cases?
Yeah, absolutely.
Okay.
So yes, some of what we learned through the SANE program it can be applied to pretty much any kind of forensic work. However, it is best practice to also get extended training on intimate partner violence examination, strangulation exams, and child abuse, because the sexual assault component of it does really touch on a lot of those areas, but we also want to make sure that our examiners are all equipped to see all of those kind of patients. But yes.
Gotcha. And real quick, what is the clinical training like for forensic nursing? You kind of touched on it. It's a long process. You've got various hours for different topics, different subtopics. Is that what I heard you saying?
Yeah. So, and one of the things we try to do here is make sure that there's not just one examiner in the room during any of these kind of patient interactions. Number one, for legal reasons. Two, a lot of these involve sensitive parts of the body. So you want to make sure that you're abiding by chaperoning laws and just being cautious. And also, it's a great way to train everybody. So when I have precepting nurses, I bring them into exams. I have them do note taking, maybe help with swab collection, help me with photography, so that it's constantly the nurses are constantly active in the role of forensics. So
Gotcha.
even if there's not a kit for 2 months, they're still actively involved with cases.
Gotcha. That makes a lot of sense. And real quick, federal agents, what cases are different between the federal agents and local law enforcement? You kind of touched on that based on some of the different rules they've got to follow and the type of violence that's happening.
Yeah, exactly. So the feds are not going to pick up misdemeanors. Generally,
Gotcha.
we're going to be talking about felony crimes.
Gotcha.
So if it's a misdemeanor, and unfortunately, sometimes domestic violence follows under more of a misdemeanor than it does a felony. And so if a tribal community doesn't have really good codes and legislation that help support victims of domestic or intimate partner violence, then those cases are really falling through those cracks.
Wow, that's unfortunate.
Yeah.
All right. Anna, thank you again so much for providing this information. Again, it's been recorded. It will be on our website later. And everybody that attended, I will send you an email with some of the follow-up information, and be sure to go ahead and do the evaluation. And we can make sure that you get your certificates for that. And Ernestine, thank you again for helping us get Anna on. And like I said, we've got programs coming up on August 13th and September 3rd. August 13th will be about the directives, and we'll have more information about that. And again, I'll send that information out. And Ernestine, any closing statements for you?
No, just thank you to everyone who attended today. Thank you, Anna. Thank you, Melanie.
Great.
Thank you guys so much for having me. Really appreciate it.
All right. Thank you, everybody, again for joining us. And we look forward to seeing you at a future upcoming webinar. Thanks, everybody.